Hello, we have returned to this place. Welcome to Motility On, your reliable connection to the fascinating world of digestive motility. And today, something extraordinary. All the classic pie of non-cardiac origin truly stems from gastroesophageal reflux disease. Is that really the truth? This question many of us ask every day in the office, increasingly receiving patients from the Motility Center. And for that, I am here, Fabio Teixeira, together with Carla Granja, to bring a little bit of this knowledge pill of the reason for each one of you. Hello, Carlina. Welcome to our cozy place.
Friends, so we are here today to talk about non-cardiac chest pain, right? And this non-cardiac chest pain is not always gastroesophageal reflux disease, right? However, there is a highly intriguing detail, namely that during our investigation of these patients and subsequent performance of an endoscopy, if the endoscopy fails to reveal any indications of gastroesophageal reflux disease, we proceed to conduct an esophageal monitoring examination in order to assist us in establishing whether or not this patient is afflicted with gastroesophageal reflux disease. But it is interesting that we understand that in order to have the correct positioning of the pH metry and impedance sensors, we have to perform esophageal manometry. And this esophageal manometry then will complement our reasoning. If this non-cardiac chest pain is associated with the esophagus, we are conducting the two examinations that will assist us in this process of reasoning and provide valuable insights. To begin, esophageal manometry is initially conducted, followed by high-resolution esophageal manometry, which encompasses therapeutic tests and protocols for both sitting and lying positions. These procedures offer valuable technical nuances that can greatly assist us in improving our diagnostic and treatment decision-making process. If in esophageal manometry we already observe findings that are suggestive of gastroesophageal reflux disease, a failure of the anti-reflux barrier, that is, a hypotonia there in the region of the esophagogastric junction of the lower esophageal sphincter, an ineffective esophageal motility, which is the motor alteration most frequently associated with the reflux disease. We will then carry out our sphincter localization properly and ensure the correct positioning of the impedance pH metry sensor, which will provide us with the concrete data of acid disposition, enabling us to determine whether this patient has gastroesophageal reflux disease or not. And also, as we have seen previously, allow us to correlate if the patient has experienced the episode of chest pain during monitoring the episodes, if he had a correlation with the episodes of reflux. In manometry as well, we can see other data which are esophageal motor alterations, which can also be related to chest pain, such as hypercontractile esophagus, esophageal spasm, and other motor alterations observed in manometry, and that can also justify or are related to this non-cardiac chest pain. Isn't that right, Fabio?
It is interesting, Carla. I would simply include what you said. The initial significant aspect when you are encountering a patient with chest pain is actually the referral from the cardiologist, ruling out a cardiac disease. Starting from then, we open up the range for diagnosis. We need to have a radiological study. We have to have at least a chest X-ray, as this symptom may even lead us to a tomography scan. In endoscopy, the main objective for us is to search for mucosal lesions. Are we facing erosive reflux disease? We are not. Then the biopsy is done. Remember the eosinophilic esophagitis, as we have already discussed this with you. From then on, place this patient with guidance. What you said, high-resolution manometry today brings us a protocol seeking conclusive diagnoses. And high-resolution manometry, when directed towards dysphagia or chest pain, allows us to have guidance within the Chicago 4.0 scale in order to better organize our diagnosis. But besides everything, manometry will give us the real moment to place, where to place the impedance sectorization, the pH metry, or the esophageal pH metry, when we just want to know if there is or not correlation of that symptom of chest pain with reflux disease. So this is going to be very important for us so we can work for the patient based on what he needs the most, which is to improve quality of life and symptomatic correlation of what he is experiencing. Puts this, it is not only about reflux disease, but they have the potential to make a significant difference in guiding the treatment in the most optimal manner possible.